Welcome to State of Reform's virtual series, 5 Slides We're Discussing, with some of healthcare's most thoughtful leaders. And now, the host of State of Reform, DJ Wilson.
Hello, and welcome to another 5 Slides We're Discussing episode, talking about today the Arizona health system's response to COVID in this grueling time of this pandemic. And I'm super excited and honored to introduce you to our panelists here in just a second. Let me first say my name is DJ Wilson, one of the folks that hosts the State of Reform Health Policy Conference series. And we're honored to be kind of living in this virtual space with you, where we're trying to meet the need of fostering community and collaboration and the safe tables that help bring people together, but just doing it in a time of COVID, of course, with these virtual settings. So today we have what you will experience at our virtual conferences. If you are able to join us, you'll be able to see our panelists speak, interact with me, and also interact with you. On the right side, as you'll see of the screen here, is a chat box where you can post questions for one another and for the panelists. Of course, many people are in this webinar, excuse me, in this virtual conversation right now who are experts in their own right. And so your questions may well be answered by the people on the chat thread in addition to people here on our panel. When you see a question that you like, go ahead and hit upvote. You can do that, and that will prioritize the questions from the community to make sure that we get the ones that are most interesting to most people. I know we've got about 150 folks who have registered for this, and really across the states that we cover here at State of Reform. I already see some names who are signing in from Alaska and Washington and Texas and other parts of the country. So super excited. We're also going to have a couple of polls for you in real time so that we can gather your feedback that way. That'll be related to some of the content that you'll be hearing from us here throughout the conversation. So without further ado, I want to jump right in to introduce our panelists from the Arizona. I should have remembered this because I always screw up health and hospital, but the Arizona Hospital and Health System Association, good Lord, Arizona Hospital and Healthcare Association. Ann-Marie Alameddin, thank you for being with us. Roland Knox, the CEO at Mount Graham Regional Medical Center. Thank you, Roland. And Will Humble, the Executive Director of the Arizona Public Health Association. Thank you all for joining us. Ann-Marie, let me start with you since I so brutally massacred your organization's name. Tell us a little bit about the work that you're doing and how you're spending your mental energy these days.
Yeah, well, certainly, like all the hospitals around the state have been totally engaged in COVID response, tracking from a policy level what we need to be advocating for and really shining a light on in terms of some of the relief that hospitals need. And we also really facilitate the statewide as chair Arizona Coalition for Healthcare Emergency Response. So we work regionally in the 4 regions of the state, engaged on tracking, PPE shortages, staffing shortages, other supplies. So just engaged in a lot of different ways, trying to serve our community.
Yeah, and I should say I really consider you one of the most thoughtful voices, Ann-Marie, on the providers and specifically, obviously, hospital experiences in Arizona. So I appreciate you joining us. Roland, tell us about the work that you're doing at Mount Graham and what you are doing in the day-to-day experience in COVID these days.
Well, thank you, DJ. Yes, it is day-to-day, and it's actually hour-to-hour. It seems like how we react to things. Of course, when this all came together and for our own organization with our first case in the community, which was on March, a day-to-day reaction as to where do we need to put our resources today. What do we need to plan for to get us through this day and into the night shift and then through the night and then the next day too. And we have a lot of really good resources, a lot of good employees, the facility, the community is very supportive. I caught what you asked is where are we spending our mental? And I think that's really a big piece of it too for myself and my administrative team and the leadership, but as well as the staff. And I think it's that trying to expect every day what's going to walk through the door, what patients are going to come to us today that we need to help. And I think just that anticipation is, are we ready for them? Do we have everything that we need? And how will we help them through the system? And I think that's really, again, where we're spending our energy is just trying to anticipate. And since we are a response industry and we do respond on a day-to-day, hour-to-hour basis, that's really where we've been focused, make sure we're here to care for those who come to us.
Yeah, good. Thank you, Roland. And Will Humble, the Executive Director of Arizona Public Health Association. Will, tell us about where your headspace or how your headspace has been filled in these last few weeks and months and the work that you are doing at the association.
Yeah, so the Arizona Public Health Association we're a nonprofit, and our main mission is to really provide an independent voice for public health. We have about 700 members that are members of our organization. A lot of our members join because they work for, say, example, executive branch agencies or county health departments, and because they work for elected officials, sometimes they don't have the kind of advocacy opportunities that they'd like to have. And so they join an organization like ours where we can have that independent voice. And so we've been exercising that voice really since March by providing, I would say, education and maybe even you could say color commentary to journalists around the state to help fill in the gaps of information that are missing from executive branch agencies, county health departments, and the like. And because I don't work for an elected official, I have a board that I report to. I'm able to really dive into some details that I think people would not normally hear about because we are able to have that independent voice. And so as we go through the outbreak, I've talked about at the beginning, the importance of testing, even when, the situation, the executive branch agencies were dismissing it as relatively unimportant. We were talking about how it's really the core and the base of the pyramid. This week, we're working really around advocacy to structure or help encourage the state health department to put together some criteria that school districts could use to determine when it made sense to open in-person instruction. So we're using our advocacy voice to try to influence policy, basically.
Yeah, great stuff. So the idea of 5 slides is that we've got the tools of this digital age where we can use multimedia to foster these conversations, where we can bring our audience in. Each of you has brought a slide that speaks to, again, where your headspace is, the things that you're focused on and thinking about. I want to tee up our first slide. This is one that we've brought from our team at State of Reform. And school's starting. And so as people think about sending their kids back into the fall, it worries some parents, creates a little bit of anxiety for grandparents, and folks are thinking about it. This slide is taken from a recent study out of Israel featured in the epidemiological journal Eurosurveillance. It's a public health journal in Europe. And in Israel, they start their school back up in May. And so you'll see in the slide there on the left, this is in the city of Jerusalem or the Jerusalem district where they had an early spike in COVID cases, as many places did in Europe and Southern Europe and the Middle East. And then they got it under control. And then in about the week of May 17th, they had a huge spike, showing up in May 24th, of folks who are 10 to 19-year-olds. Those are school-age kids. That's where you see that big spike. And even though that spike comes down a little bit because schools start to close, over 125 schools in Israel closed during that time, you start to see the onset of adults with kids in the home getting sick. So it's one data point on what going back to school looks like. Ann-Marie, let me ask you first, what are your thoughts as a citizen and as a hospital association professional as you think about the complexities of going back to school?
Well, first of all, I really think it's important to be looking at lessons learned from other countries and communities as they open schools. We've seen some improvement in Arizona in terms of our case rate going down. And our biggest, I think a big risk area in the future as schools start to open is what this is going to do to our case rate, and to make sure that we are arming school boards, the Department of Education, with really good public health driven data and metrics so that we can open schools safely. And so I think it's really important to be looking at lessons learned out of Jerusalem so that that spike doesn't happen here, that we can avoid this and we can take really good data and implement it at the local level to make sure when kids go, we all want kids to be back in school. We just want to make sure that we're doing that safely. So I think it's really important to have this conversation and to look at data like this so that we can do it safely in Arizona.
So Will, you've got a slide later that connects very clearly policy choices to new infections in COVID. What are you expecting as a public health professional? What are you expecting to see from communities going back to school in terms of new infections? What do you think?
Yeah, so that's as you said, that ties exactly into the slide that I'm going to talk about in a few minutes. Because I don't know what to expect because I haven't seen a predictive model that incorporates data like what you're showing up here from Jerusalem and experiences from other countries that's been put into a model that could show us what it might look like. And there's a lot of wild cards out there because it's not just schools. There was a ruling yesterday in court that the gyms are now have to be given an opportunity to show that they can meet mitigation measures and become operational. And I don't see that as a big issue, but there's a wild card out there where, does the governor end up deciding to allow bars and nightclubs to open up again? And if that policy decision is made, that could have, in my opinion, could have more profound consequences, perhaps even than opening the K-12 system. And then the remaining question was also, what if the governor were to allow K-12 or put loose criteria in place that allows the school districts and boards to open K-12 instruction and then allows bars and nightclubs to open as well? All these are policy choices that will have an effect on both community spread and impact within the hospital systems.
Roland, as a CEO of a hospital, how do you sort of think about some of these decisions that are being made and taking place outside of your hospital, opening bars or gyms or going back to school? When you see those happen, do you think to yourself, boy, in 2 weeks' time, we're going to get busy, or 4 weeks' time, we're going to get busy? Or are you just so focused on the day-to-day that you try to focus on the things you can control, not the things you can't?
I think the latter point is what we do focus on often, which is what can we control? And that's really what we focus on most. But then we do anticipate, like you say, when we hear things happening and policy decisions and different businesses opening up or people now wearing masks, and we see what's happening in our own community and across the state and across the country, we do anticipate 2 weeks later things are going to happen, and 2 weeks later after that, and just how it's going to continue to cycle. And when I saw this slide that you brought and you put it there, it really confirmed in my mind, I have this constant thought about a roller coaster. And that's really what it feels like, what we have, because first it's peaks, and then it comes down a little bit and it goes, and then something else happens and it peaks again. And so to me, that's really the ride that we're going to have for the next 12 months. And how do you control that ride? Sometimes it's very, very difficult. You can only anticipate and keep your awareness of what's happening. Because I think this also is illustrative of a lot of businesses and a lot of other pieces of society that are reacting in different ways. And where we have some groups that they don't believe that this is really happening. And so those groups, we're going to see them in the hospital shortly after they have their gatherings, 2 weeks to 4 weeks. So there are things that are happening that, like you said, we can't control, and we just try to anticipate them.
Yeah. This other part of this slide you see there is that in the month of May, many, many of the new infections were among young people, 10 to 19 or thereabouts. I would just add, in that study, they said that of the kids who were symptomatic, or rather who were infected, 60% of them were asymptomatic. Other recent studies just in the last week have said that some kids as young as in the kindergarten to fifth grade area have as much as 100 times the virus load, though they are often asymptomatic. Meanwhile, we've also seen that in some places like Iceland, there have been almost zero transmissions from young people to adults. and that generally speaking, it's very rare that young people in the K through fifth grade, for instance, are transmitting to adults. So they may have a lot of virus and there may not be a consequence. We're still trying to figure that out. Let's go to our next slide. This is one that you've brought to the conversation, Ann-Marie. It looks like the slide that I've brought to you, Ann-Marie, is not up there, but you know what you're showing us, and it's up on our screen for our viewers. Walk us through the image that you've contributed.
Sure, absolutely. So, we all are looking at Department of Health Services, data dashboard every day. And I think it's really important to look at metrics like ICU capacity. We saw back in July, ICU capacity was up to 92, 93% average statewide. Now the ICU utilization is more around 88%. But I chose this slide because I really wanted to focus on the healthcare workers, the clinical staff that are on the front lines, the exhaustion that they are facing, and the shortages that Arizona is facing, to just highlight the very human element of this. And our clinical staff is not an endless resource. We're hearing from hospitals, this week that a lot of staffing, hospital staff are hearing, a lot of people are calling in sick because they actually are sick or they're just exhausted. They've been taking seven shifts in a row. And we have a clinical staff shortage and we need reinforcements. And so this is a finite resource that we need to make sure that we are preserving and that we are protecting. And these are the people on the front lines. And just to sort of highlight, I think, the very delicate nature of the situation right now. We have, a lot of staffing agencies are in Arizona. I think it's difficult for hospitals to secure additional staff. We've seen prices go up tremendously, 4 times what they normally are. So some hospitals are unable to afford additional staff because of these price wars. So there's obviously a very real element with regards to patients and people getting sick. But we as a community have to really keep our eye on the ball on public health interventions that make a difference, to look at the data, because our healthcare workforce are tired. And we know that this is a marathon. It's not a sprint. And a lot of us are getting, pandemic fatigue, but no group greater than people who are providing the direct care to patients, and to just really put that human face to who's really on the front lines.
Roland, how about as CEO of a hospital, how are your people doing? Give us a sense, we don't get a chance to see what it's like on the inside of hospitals during this pandemic. Tell us about what it's like and how your people are faring.
That's a really good question. That's a day-to-day focus too, is how are our staff doing and how are they mentally, how are they physically, and are they prepared for what may come their way any given day? And again, it ebbs and flows. One day they can be very strong, but then they have a family member that may present, or a family member who may not be feeling well or has come down with COVID, and all of a sudden becomes even more impactful for them emotionally, for their concern for their family members that are at home or maybe in the same hospital of where they work. But emotionally, they are tired. And so most of the staff that we have are able to work their 3 12-hour shifts and then have a day or 2 off. And that helps them refresh and then come back again for 3 more shifts or 4 more shifts or whatever it may be. And so because of how they're scheduled and because of what we have right now with our staffing levels that we have, we're able to provide those mental and physical breaks from the work itself. And so we have a very strong group of people, and they're committed mentally as well as physically. But I would say the mental fatigue is the thing I worry about most for all of them.
Yeah. Will, I wonder if you could speak about the broader healthcare workforce community. The Public Health Association has a diversity of members and of organizational types, but you're not the the medical association, you're not the hospital association, but I'm wondering if you could just sort of speak to how the level of anxiety and exhaustion is filtering out amongst the rest of the workforce and other organizations, even though the brunt is often taken by hospitals.
Yeah, so our membership is mostly the public health workforce, so I could talk a little bit about that. And I would say that the biggest frustration among the public health workforce is the fact that the vast majority of the decisions are made by one or two people, the governor and the health director. And there are many people that feel like they have something to contribute to those decisions, but aren't given the opportunity. And the flip side of that is that when they work, for example, at a county health department, they end up in a way, like what Roland was talking about, they end up becoming responsible for managing the results of policy decisions that they didn't have any influence over. And so that can be super frustrating. It's a different kind of fatigue than a healthcare worker, where you're talking about, shift after shift after shifts and dealing with that kind of an emotional drain. It's a different kind of emotional drain where you feel like you see mistakes, you see opportunities to inform the decisions that you're not given. And then you see mistakes being made at the policy level that will have a direct impact on on the things that you will need to do to try to manage the epidemic at your level. So I'll just give you one example of that. For many, many weeks, the turnaround times for the tests, the PCR diagnostic tests for community testing have been really quite bad. Hospitalized patients get their results back, within hours or the most a couple of days. But people who get tested in the community, they might not get results for, say, 12 to 14 days. And the county health departments are expected to do a good job with contact tracing. And yet they're dealing with a system that provides them specimen results 12 to 14 days after the person took the test. Well, how can you can't do good contact tracing when the results are antique like that? It's too late. And so they see system problems like this and they see solutions, but they're unable to translate that into policy. And I think for many of our members, that type of thing is the biggest frustration and the biggest drain emotionally.
So let me ask you all this question, or rather whomever would like to respond can. It comes from, and I'm sorry if I mess up your last name, Kim McAloo. She's asking about how Arizona is doing specifically about securing supplies for the medical community, not just testing, but PPE also. And how well would you say the governor is involved and his administration? And how well is the federal government assisting Arizona? I know that's, like I said, I'm going to throw that open to any of you that'd like to take a crack at that.
I can sort of provide my first response with regards to supplies. I think supply chain, at least on the hospital side, that we have a really good work group that ASU helps convene to identify supply chain issues. PPE was an issue, a severe issue back in March and April. I think the supply chain has loosened up a little bit with PPE so that is sufficient for hospitals. But on the testing side, and I'll just kind of go back to Will's comment there, we still have some hospitals reporting that it's taken 5 days to get testing results for inpatients back. So testing continues to be a problem even on the hospital inpatient side. Lab directors, we had a call last week with lab directors. There's a shortage of reagents and testing supplies. And that's really the private market. And so there is not, we don't have the feds that can come in and provide that. It's the individual, Roche and Abbott who have those reagents that match their materials, and there's a shortage. So I'll focus on a bright line here, is that we are getting a significant number, $10 million worth of ventilators to Arizona in a number of weeks that Department of Health Services contracted with ASHA to help secure. So that is one bright line, that we will have plenty of ventilators that will be coming into the state. There will not be a shortage there. And I believe that was federal funds that helped procure that. It's just more conversations, collaborations to identify where the kinks are, so that we could shine a light on it and get the policymakers to somehow, or the private sector, to free that up.
I know we're going to come back to this question of policy here in a little bit, but I want to move to your slide, Roland, and have you walk us through the graphic you've brought for us today.
Yeah, so this slide is one, as you can see, just by the top of it, it talks about providing staffing and what we've been talking about, and the people that are involved with this. And so on a day-to-day basis, for us, we've historically had 3 hospitalists that work 24-hour shifts, 5 shifts in a row. And one of them works in our community, lives in our community. The other 2 come to our community from living in Tucson, which is about 2 hours from here. So they're not readily available. But we were able to cover our coverage that we needed historically. And though that's been something in the back of our mind, is what happens if one of them gets sick or needs a little help or something like that. We've always thought, well, we can always just call on our local providers, and they've all been willing to do that. And also physicians in our ER, and they can cover for an hour or 2 or whatever it takes to get another hospitalist in. Well, given since COVID, what's happened is that now the reality is let's put a plan together. Let's know what the trigger points are. How do we know when we're going to ask others to help? For instance, others in our community that are local providers that have their own day-to-day clinics that they have to worry about. Or our emergency rooms are really the first responders, the people that are coming through the door. And not at any given minute do we know whether or not they're going to be able to help the hospitalists on the medical floor. So really, it became very nerve-wracking for all the providers to know, what are we going to do? Or what happens if I get sick? Or what happens if I just need a few hours of rest? What happens as our census goes up from the normal 40% up to 85%? And I'm just exhausted because the acuity level is higher and we have more people on ventilators. And, that's what their job is to manage all that. And they need probably 4 or 5 good hours of sleep. What can we do to help them? And so as you can see, we've walked through this from the top of the hospitalist sick call on the left-hand side, what we do and how we proactively approach that. And again, the local providers become ones that are very important to us at that point if we can get locums or one of the other hospitals can fill in. And then on the right-hand side is that addressing what if we have an instance of where we need help right now. These doctors are exhausted, or the doctor is exhausted, and they need to just go and take 5 or 6 hours of rest and just get their wits back about them and can care. And how do we take care of that, and how do we fill in those short terms? So again, this is really about the people that are involved, and it's really about things that we thought about that weren't front and center on our target, so to speak, of what we had to solve each and every day. And so putting together a plan so that people know, where do I fit into that, and when would I be asked to fit into that? So again, this is all something that has come about with the pandemic and COVID, is that these concepts of how you react to things are concepts until you have to put them in actual use. And so that's what we're being forced to do with a lot of items that used to be concepts that, okay, now we have the experience, now we know how to do it.
Yeah, it's sort of speak to how your community has to compete. It sort of becomes like an auction, right, for folks who can drop in and support communities. It's got to be really difficult to have to struggle for a finite group of resources, staff, caregivers. How do you end up working as one community with or in competition with others?
Yeah, that's a really good question. Again, before the pandemic, oftentimes we would call each other and say, hey, can you help us with this? And oftentimes they could with staffing, whatever that may have been. In today's world, everyone, because you don't know what's coming through your door next. So today, yeah, you have plenty of staffing and your physicians are fine. But, when things ebb and flow, and like I commented before, the roller coaster, and now the peak starts happening and they start coming through your emergency room, or they start being referred by the clinics, or the health department has an outbreak that they've come across and they're sending people to us. So it is more difficult, and it is more difficult to get even locums companies to help you with it. but we are becoming more aware of other resources that we didn't even think about before.
So Ann-Marie, when it comes to advocacy, recognizing the strain that America, but Arizona is already in terms of workforce shortages, and how COVID has exacerbated some of this to your point earlier and to Roland's point here. How do we, Emily Berger has a question about how do we build a kind of workforce as a result of learning and lessons from COVID? How do we build the kind of workforce that will help us in the future?
I think that's a really great question. And I know certainly in COVID response, I've certainly been talking with other state hospital association executives nationally, as hotspots emerge across the country. We almost have to think about a national clinical workforce. How can we help deploy? Because currently, we leave it to the staffing agencies to help fill that. So how can we move a little bit more efficiently, more agile, have more agility to meet the needs of the communities wherever those hotspots might apply? I mean, I think the lessons that we're going to learn from COVID are going to be probably years that we'll be sort of unpacking and implementing. But a regional approach to healthcare, to be able to deploy to hotspots, looking at supply chain, having maybe more domestic productivity so that we're not so reliant on, distant manufacturers. I mean, all of these things I think will change as a result of this, because we've seen our vulnerabilities. This is at many times a private market scenario, and when there's a public health emergency like this, we really need a national, a state approach or a regional approach. So I think we'll be seeing those changes on staffing, supplies, and policy changes.
Yeah. Well, I wonder if you have a personal observation going back to this idea of advocacy. I think in the pre-COVID world, there was a lot of focus on primary care as a place to invest. There's still a focus there. Sometimes we get caught up in things like payment reform and some of these administratively ethereal kind of things. I think COVID has really put a focus on caregivers and the importance of caregivers as people. When we get back to a legislative session, we're advocating again, we're thinking about workforce and recognizing the world has finite resources. Should our post-COVID workforce focus be on community level workers or more hospital, what I consider high capitalized or workers with a high level of capitalization to support them? Should we be in the setting or out in the community if we had to put a focus on one or the other? What do you think?
To be honest, I think we were on the right track for the last few years by focusing on primary care, especially in rural and underserved areas. One of the core areas of our advocacy over the last few years has been to boost graduate medical education opportunities in primary care, especially in rural and underserved areas, and give more opportunities to do residencies in those parts of the state because of the acute workforce shortages that there are in all kinds of healthcare disciplines. Same thing goes for the state loan repayment program is one of the examples of where we would do that, the National Health Service Corps. So I hope that one of the things that I hope that we don't overcorrect is what I'm saying, because I think that if we overcorrect and start planning too much for these kind of extremely rare events, you can get sidetracked and lose focus on what you had been trying to do, which is to keep the primary care workforce and the healthcare workforce within the rural and underserved areas solid, or boost and improve that. So I think that's just something that we need to watch out for, is that there can be a tendency to overcorrect when you have an event like this. And certainly it's been super disruptive. But remember, these pandemics are not frequent events. And I think it would be a mistake to divert scarce resources to plan for extremely rare events when, in fact, the core public health principles of prevention are what really is what keeps families and people healthier in the long run.
Speaking about prevention and avoiding the steep curve of infection rates, let's turn to your next slide here, Will. Walk us through what you've brought to this conversation.
Okay, so first of all, the font's really small, so everyone, if you want to see the actual date, you'll have to scoot way up. But my discussion's going to be a little bit higher level than that. So what this represents is, it's just a slide I put up to emphasize the importance of public health officials and governors working with their academic partners to help inform the really important policy decisions that they need to make during events like this COVID-19 pandemic. What this slide represents is actually, this is the work of the Arizona's modeling team. So it's a consortium of people from Arizona State University's Biodesign Institute, and then some staff from the U of A, University of Arizona College of Public Health, came up and volunteered their time to use the available data that's from way back at the beginning of the pandemic and do some predictive modeling on their own time. They didn't get paid for this, to help with the hopes that it would inform the policy decisions at the very top of state government. And so what this team did was put together a predictive model, and you're looking at the results of that model run from April 21st, using the best available data from what we had observed in Madrid and in Lombardy over in Europe and in New York earlier in the year, to use those data to inform a predictive model to show an elected official how the various scenarios are likely to play out depending on the decisions that they make intervention-wise. And you're looking at three different scenarios here. The solid lines are the three different, well, I would say the top line and the bottom line, the blue line and the yellow line, are the two predictive models under different policy decision scenarios. And so the bottom line is what the model predicted what would happen if we ended the stay-at-home order on May 15th and then slowly phased out of that stay-at-home order, where you would slowly add new businesses to the essential services category and essential services business categories. And you can see, and actually there's the bottom line is if you stayed at the stay-at-home order. So if we would have stayed at the stay-at-home order, you would get that very flat line that you see at the bottom. If we would have slowly phased out of that stay-at-home order, and I think that line is, I'm colorblind, it's either yellow or orange-ish, that second line from the bottom, that's what the case counts would have looked like if we had phased out of the stay-at-home order, again, according to the predictive model. The other two lines, represent, the blue line represents moving out of the stay-at-home order on May 15th the way we did, which is basically removing the restrictions, encouraging businesses to follow the CDC mitigation measures, but essentially allowing any business, including bars and restaurants, to open on May 15th. And that's precisely what we did. Now, if our elected officials had looked at this model and helped inform their decision, they could have seen that, in fact, we could maintain our hospital capacity if we slowly came out of the stay-at-home order in a more phased and thoughtful way. That's the orangish line. And have been able to, we could open up the economy slowly and maintain our hospital capacity. On the other hand, what this scenario showed, and this again was published on April 21st, so this was available to elected officials. The blue line is what the model predicted what would happen if we left the stay-at-home order the way we did, which is going into a fully voluntary system with every business considered that could be open, including nightclubs and bars. And the X's that you see on the screen represent what actually happened. So this is a model. This is looking back on July 1st to the April 21st model and looking at the reality of what they predicted at ASU Biodesign and the modeling group compared to what actually happened. And you see that dotted line with the little black dots. That's the current model best fit. That's the best fit for the data that actually happened. And so what you see is that the policy decisions that were made were essentially based on that scenario that you see, the blue line. And what we got was really close to that scenario. But if the elected officials had looked at this model and helped frame their policy decisions using this information, perhaps we could have made a different choice, phased out of the stay-at-home order in a more organized way, and the X's on this slide would have been much lower on the y-axis. So that's and the reason I brought this slide up is it shows you how important your academic partners can be in showing you ahead of time what the likely results will be from various policy decisions when you're a crisis like this.
You know, Ann-Marie, when I see this slide, I'm reminded of a new concept. It's not really a new concept, but it's a new framing, I guess, for me, which is to say, a year ago at our conference, we were talking about social determinants of health. We'll continue to talk about social determinants of health because those are smart and important, but there are these new things called political determinants of health. Mm-hmm. Again, this is something we all know about. The policy impacts our healthcare system and situation, but that the political determinants of our time will directly impact our health. How would you measure the politics? How effective are community politics, our local politics, our state politics? Forget about federal for a minute. How have our politics supported a good public health response here, or maybe been an obstacle to it?
Well, I think, one of the most important public health interventions recently is the mask, ordinance that individual municipalities and cities can enforce their own local requirements requiring masks. I think that was a really important policy decision that was made by the governor to allow local municipalities to have that control. If there wasn't going to be a statewide mandate, that individual counties could look at what their rate of community spread was, and that they could take action accordingly. And that has made a big difference. And I think people were looking at the data and they saw that masks unequivocally made a huge difference and really improved the decrease in spread. So I think we need to do more of that. We need community engagement, community leadership to do that. And then we all need to do our part. This is I think a public health emergency like this, pandemic, it requires us all to act. The healthcare system cannot do it alone. We do it in partnership with our communities, and we all absolutely have to do our part. So I think the policy decisions absolutely matter. But that was one that I think was really important. And had that not happened, it would be really frightening to see the predictive modeling of not having any mask ordinances in Arizona. I don't think we modeled that, but that's frightening to look at how close we came in July with our capacity really becoming quite thin.
Yeah. Roland, I know you're a hospital administrator and not a public policy consultant, but let me ask you to put some of this time in context. And Marcus Johnson, in our comments here from the Vitalist Health Foundation, is talking about the frustration that healthcare workers and public health workers and scientists and researchers are feeling about the politicization of healthcare right now. Put this time in context in your career. Has healthcare always been politicized? Or is this unique in terms of the reach of politics into our healthcare considerations and healthcare system?
That is a really good question, and I'll put it in context with my career. I've been in healthcare 16 years, and I spent 7 years here at this organization at Mount Graham as the chief operating officer, and then I was a CEO at another smaller hospital down the road for almost 9 years there, and now I'm back here for a 7-month period. And so I'll put it into context really as my role as a CEO and really at the hospital I was at before the context of the politicizing healthcare. And what I really saw, prior to the pandemic is the politicizing of small rural healthcare and the reality check of that's in essence. The majority of our people that live in the rural healthcare, they're very independent and they want their local hospital. However, because of population bases, they're not as large and there's not always the money distribution to be able to support that need within those communities. Now, Medicare and Medicaid help with that, but that's not always the answer to it, but it can be very political. So for me, seeing the political nature of the pandemic takes it to even a higher level, and to the higher level of where every single day, and was it in the month of April, May, and June, of where you turn on the morning news and you would have a press conference by Governor Cuomo in New York. And we all got to know his ties that he wore every single day. We all saw that, what was happening, and to hear that. I'd never seen that before. And so that took it to an even higher level. I think it's going to stay at that level, at least for through the end of this year, calendar year 2020. But no, I'd never seen to this political nature that it is. And it's one that in some parts has helped us as rural healthcare, and the fact that the funds that have become available from federal resources are really what's helped keep our doors open. And I say that, and I think I can speak for a lot of rural hospitals, is that was really a lifeblood that we had to have when we had almost a shutdown occur in March and April of what was happening in healthcare. So the political side always has the positives and it has the negatives. And it is, I think, peaking right now in the political nature.
Looks like for those of you who have responded to this recent poll we just posted about the grade you would give Arizona's public policymakers, a little over half give Arizona's public policymakers a C grade, which is passing, but there are no A grade votes and no F grade votes there yet. I want to switch to our last slide here, but actually before I do, I want to get this question in from Len Kirshner to you, Will. If you would just walk us through briefly, educate us, give us a lesson on PCR testing and virus testing versus antigen testing and some of the nuances there.
Yeah, so there's three different kinds of tests that are out there. I'll start with the PCR testing. That's the one I think most people are familiar with. So that's a diagnostic test. So you're most familiar with that test by the really long Q-tip that you've probably seen on the news where people are going through the drive-through clinics, and that Q-tip goes supposed to go all the way back to the nasopharyngeal complex there. It's really far. That's where the specimen comes from. They run that in a laboratory. They amplify the genetic material and come out with a test of, do you have COVID-19? Do you have the SARS virus present? So that's the PCR test most people are familiar with. Another test that is becoming, I think, more useful and more used in the community is an antigen test. And that's also a diagnostic test. But the difference between that one and the PCR test is the PCR test, the sample goes off to a laboratory. And as I mentioned earlier, can take you've said that some of the hospitals are waiting 5 days for those results. Community tests are sometimes waiting 12 to 14 days. And so with the PCR test, that long test that goes off to the lab, it gives you information much later than you need it. The value of the antigen test is that it's a real-time test that you can take in, for example, a healthcare facility, let's say a nursing home or an assisted living center, or you could use it on the staff within assisted living and skilled nursing. And it's a rapid test so that it's a diagnostic test. So it looks for the presence of the virus, but but you get the results right then and there. Now, the issue with it is that it's not quite as accurate, both in specificity and sensitivity as the PCR test, but it gives you results right away, which means the data that you get back from the antigen test is very actionable. And so I think we are starting to see more and more providers at assisted living and skilled nursing, especially getting more enthusiastic about antigen tests. That's the rapid test that's diagnostic. The other nice thing about that is that the FDA has given what's called emergency use authorization for pooled testing with the antigen test. And what that means is that if you're, let's say you're at assisted living or a skilled nursing facility and you want to test your staff to make sure that they don't come to work sick and get your residents and patients sick, you can pool and test 4 of your staff at once. And if it turns up positive, then you have to operate under the assumption that all 4 of your staff are positive. But if it turns up negative, then you know that all 4 of them are safe to go to work right then and there. And because the antigen test is real time, it gives you information for that shift. And you can send your team, all 4 of them in. And it cuts down on the cost because the antigen test, because if you pool it, it's going to cost 4 times as less as it would have. So the PCR test is that diagnostic test where it gets sent out to the lab and sometimes doesn't come back for many days. The antigen test is a real-time rapid test, also diagnostic, or perhaps you could call it a screening test, but it's looking for the actual presence of the virus, and you could use it with pooled folks. And so that is becoming, I think, of great value to especially business owners in the healthcare industry, especially assisted living and skilled nursing. And I won't spend too much time on the antibody test. That's the other category of test. And that test just basically tells you, it's a blood draw, and it shows whether you have the antibodies to the virus. So for example, I'll use my daughter as an example. She lives in Brooklyn. She was taking the subway in March. She lost her sense of smell for 2 weeks. And this is before we really knew that that was a definitive symptom of the COVID-19 illness. And when she came back to our house to work, because her job got shut down, I said, why don't you go down to SnorQuest and get a blood draw and see if you have the antibodies, which she did. And she turned up positive for the antibodies. And so that's a test that's not diagnostic, but rather tells you that at some point in the past, you've been exposed to the virus because you've got antibodies. But that still provides you actionable information because it tells you that you're at much lower risk. Obviously, there's a chance maybe she can get it down the road again. But she was the person that we sent out to the grocery store when she was living with us because she had the antibodies. So those are the 3 categories of tests, Len.
Good stuff. I want to turn to our last slide here, which comes from the Substance Abuse and Mental Health Services Administration and the federal government. It charts the rise and fall of mental health and consequent substance abuse or substance use during pandemics or disasters. And this slide, frankly, shows us that we've got a long ways to go. Some of our viewers may have seen this before. I think it's an important one that demonstrates we're on a roller coaster, as Roland spoke to, and it may get much worse in terms of our mental health collectively and substance use in our communities. It may get much worse before it gets better. So I want this to just inform your experience for folks watching. It's okay if this is hard, because it's hard for everybody, and it's certainly better to talk about it than to keep it in, because we're all going through it. But let me ask you, excuse me, Roland, let me ask you, as we start to narrow or run out of time here, what gives you hope about the state of our COVID response, about how Arizona is doing? What are the things that you look to and you say that is good?
Usable lessons learned. I think that's the part that really pulls us through each and every day, because every day we learn from what happened the day before. And I think as a state and as a country, and I know for our hospital, we're learning every single day, and it all centers around people. People, they need guidance during these times and of crisis. People are continually seeking to improve. We all want to learn. We all want to do better. We all want to say, what happened before? How can we make it better? And what else gives me hope is that people really do care about other people. And the people in the community care about the healthcare workers that have helped them. And it's really been illustrated with so many people reaching out just to say thank you to healthcare workers at the hospital. For the month of March, or April, I should say, there's probably a day that the staff in our emergency room probably didn't have to buy lunch because everyone in the community wanted to buy them lunch. So people really do care about other people.
Yeah, great stuff. Ann-Marie, what gives you hope?
What gives me hope is I think the ability, back in March, when we had the stay-at-home order, and then in July, when we've been coming down on our case counts, that we do have the ability to come together and flatten the curve, and to improve our numbers. It's relentless, and we have to keep it up, and that becomes exhausting. But we can do it if we all really put our mind to it and focus on it. And that we have good sort of data-driven policy decisions that help guide us. But we can do it. We did it. We flattened the curve, back in April. And we made good progress in July, but we've got to stay vigilant, and we've got to keep at it, because we can't rest on any sort of gains. There's more work to do, and we just have to be vigilant.
Will, what do you think? What gives you hope?
Well, I love both of those answers. And for me, that's simple. The answer to this question is a snap. I am convinced that we are going to have an effective and safe vaccine sooner than people think. The phase 2 trials have been really impressive. The AstraZeneca trials in phase 3, the Novartis, there are GlaxoSmithKline, Pfizer. There are a bunch of manufacturers that are in late phase 2 and in phase 3 testing. Phase 3 is the big final test for a vaccine. It's the real world test. Now it's complicated and it takes time, but the vaccines that in both in phase 1 and 2 have been super impressive, in my opinion, both eliciting a T cell response, but also antibody response in the folks that got that vaccine. And again, the N is small, the number of participants is small in phase 2, but the results are remarkably consistent, whether it's an mRNA vaccine, whether they're using the adenovirus transit vaccine, whether they're even the inactivated virus vaccines are showing really impressive results. And federal governments are stepping up to finance this, which is speeding things up dramatically. The UK government, the United States government spent, I think, $8 billion basically supporting the R&D and also helping the manufacturers to actually make vaccine during phase 3. So to me, I'm really optimistic about a vaccine in early 21.
Good stuff. Thank you. Will Humble, Executive Director of the Arizona Public Health Association, Ann-Marie Alameddin, the CEO of the Arizona Hospital and Healthcare Association, and Roland Knox, the CEO of Mount Graham Regional Medical Center. Thank you all for joining us, and for you watching either live or on our website at stateofreform.com. I appreciate your participation. We're going to send you a note for attendees and ask you how we did. I'd sure appreciate it if you fill that out. Otherwise, till next time, thanks for watching and keep on working hard. I appreciate your effort. Thank you.
Thanks for joining us in this virtual conversation and for your support of our work at State of Reform.